First, I would like to thank Thomas for the invitation, and I do apologize for not being with you, but it's due to familial trouble. So, yeah, I hope the next time I will be with you and be able to share data, but also beers and wine. So I'm Sylvain Audia, and I'm working in France. I'm part of the referral center network, and the topic today will be new therapeutic targets in ITP. So I will not have to go in details with ITP pathogenesis, as John and Rick already did. So I will directly move to the way we can tackle ITP in clinical practice. So the first way we can do that is to decrease the platelet destruction, and current therapies that are used currently to do that relies on steroids, IVIG, SYK inhibitors, and sometimes, but rarely, vinca alkaloids. And new therapies are BTK inhibitors, Fc gamma receptor blockers, and IVIG mimetics. So if we have a close look to what happened into macrophages, here is the downstream signalization of Fc gamma receptor. And in ITP, platelets that are recognized by antibodies can bind to Fc gamma receptor, activating a downstream pathway involving the spleen tyrosine kinase SYK, but also the Breton tyrosine kinase BTK, leading to this pathway that at the end will stimulate phagocytosis, but also the production of pro-inflammatory cytokines. So steroids can be useful to target macrophages as they will act on the different stage of this pathway. But more targeted therapies are used, such as IVIG. We don't know exactly how it works, but one of the mechanisms is the saturation of the Fc gamma receptor and the inhibition at the end of the downstream pathway, but also to the inhibition of phagocytosis. Vinca alkaloids directly acts on the cytoskeleton, thus inhibiting phagocytosis. And SYK inhibitors, mostly fostamatinib, but there is other ones such as sovleplenib, can also inhibit the Fc gamma receptor signalization, leading to a decrease in phagocytosis, thus allowing platelets to circulate into blood. BTK inhibitors, and there are many, even though rilzabrutinib is the most developed in ITP, also act on this pathway, as BTK is part of the downstream activation pathway. And there are new molecules that are like IVIG mimetics that are currently in development. And at least they can cure mice, so we'll know whether it's useful in human or not. Their mechanism of action is not really clear, but they might bind to Fc gamma receptor and inhibit either the binding of antibodies or inhibit the downstream stimulation. But at least in mice, they act as efficiently as IVIG. So it might be really promising if the results are similar in human, avoiding, of course, the use of blood-derived products such as IVIG with really frequent shortage problems. Another way to target macrophages is to use CD16 antibodies. And this has been done in clinical trial, but the use of full antibody leads to side effects, mainly cytokine release syndrome. So a way to counteract this is to use a one-arm antibody or a molecule composed of only the variable part combined with albumin to increase the half-life of the product. And all this experiment has been conducted by Alan Lazarus. So what he first observed in mice, is that phagocytosis in ITP is mainly due to Fc gamma receptor 1 and 3, as you can see here, and the use of the anti-CD16 antibody, which means that targets specifically Fc gamma receptor 3, can decrease the phagocytosis of platelets, and it was well tolerated in mice without cytokine release syndrome. So this modified anti-16 antibody could be of potential interest in ITP, but not only, as it could be also interesting in different antibody mediated autoimmune disease. Another way to tackle ITP could be to increase the clearance of antibodies. Currently, we are using IVIG to do so, but FcRn inhibitors could also be of interest. You might all be familiar with FcRn that are neonatal Fc receptors. And as you know, they are involved in the recycling of albumin and IgG, leading to an half-life of 3 weeks. Contrary to other proteins that undergo pinocytosis into endothelial cells, but also into monocytes, leading to their destruction within a lysosome. And for IgG, they will be recycled to the cell surface thanks to FcRn receptors, and then will attain again the sera, and that explains their long half-life. So when we use anti-FcRn antibodies, when you inhibit FcRn, you prevent this recycling, and at the end, this IgG will be destroyed within a lysosome. So that's a good way to decrease pathogenic IgG, but also all IgG, all polyclonal IgG will also be destroyed, and it could also affect albumin, as albumin is also recycled by this FcRn receptor. So there have been 2 medications that have been developed. Rozanolixizumab had quite nice result, but if I'm right, the clinical development has ended. And efgartigimod showed promising result, at least in one IV study that was not confirmed in a SYK study, as there is another ongoing clinical trial using IV efgartigimod. But I guess Dave Cutter will discuss this point later. So another way to try to cure our patients is to target complement, because complement can be activated by antiplatelet antibodies. And so far, we have no therapy that could be useful or at least targeting this pathway. But new therapies, such as complement inhibitors, have been tested. So the role of complement has been known for many, many years, but due to the lack of therapeutics, it has not been very well assessed in ITP. But as you might all be familiar with, there are 3 different pathways: the lectin pathway, the alternative pathway, and the classical pathway that can be activated by immune complexes, and in ITP, platelets recognized by antibodies. This leads to an activation of different complement proteins with a C3 convertase and then a C5 convertase, leading to the formation of a membrane attack complex, which at the end will be responsible for the lysis of platelets. This has been nicely shown in this paper 5 years ago. in which the membrane attack complex was measured within the sera of patients. And they observed that it was increased during the acute phase of ITP, which was not the case in patients that were in remissions who had levels similar to the one observed in healthy control. Not surprisingly, this activations was most important in patients who had antiplatelet antibodies, as you can see here, and was, of course, less important in patients who don't have antiplatelet antibody detected in the serum. They also observed a negative correlation between the measurement of membrane attack complex and platelet count. The lower the platelet count is, the higher the membrane attack complex was, suggesting that there was a correlation, and suggesting also that a targeting complement could be of interest. So there have been different studies, one that was positive, targeting first part of the classical pathway using an anti-C1s inhibitor. But I don't think there is a development in ITP so far with this molecule. There has also a negative phase 2 clinical trial, and there are two ongoing basket trial, one using, again, an anti-C1s molecule, and another one using an anti-B antibody, which means that targets the alternative pathway. And I don't know if it's wise to do that, but we will see what the result will be. Of course, another way to treat our ITP patients is to target B cells that are the cells that produce antiplatelet antibodies. And so far, we are using anti-CD20, and namely rituximab. But SYK inhibitors, such as fostamatinib, could have an action on this. I previously showed you that they act on macrophages, but they might also act on B cells, even though we don't have a lot of data on that. Why could they act on B cells? Because SYK is involved in the BCR transduction pathway, so it might inhibit the proliferation and differentiation of B cells. And new therapies are coming, of course, anti-BAFF receptor therapy, and namely ianalumab, a combination therapy using anti-BAFF with anti-CD20, and other therapies that will be discussed during the Congress, such as anti-CD38, but also CD19 or anti-BCMA, and of course, BTK inhibitors, because as the splinterizing kinase, BTK is also involved in the transductional signal of BCR. So, why targeting plasma cells? It has been known for years that they are involved in ITP, but this quite recent paper published by my friend Mathieu Maevas from Paris showed with an innovative technique allowing the detection of specific B cells or plasma cells that specifically produce anti-GP3B2A antibodies. So they can be detected and followed in different parts of the body. And what they observed is that there were, of course, increase in ITP patients in the spleen, but also in the bone marrow and in blood as compared to healthy donors. And most importantly, there are an important fraction of these plasma cells that are high affinity or of medium affinity autoreactive plasma cells. And what they also observe is that there is a positive correlation between this autoreactive plasma cell within the different sites, meaning that we can follow these plasma cells in blood, but they are also they stay within the spleen, but also in bone marrow, and this could explain the refractoriness to some of the treatment we are currently using. What they also showed in this paper, they investigate these plasma cells in 2 patients that were treated with daratumumab, an anti-CD38 antibody, and unsurprisingly, they observe a rapid decrease of these plasma cells that reappeared when the patient relapsed. So there is a strong rationale for targeting plasma cells, and CD38 could be, of course, of potential interest, and Walid will discuss that later. Another exploration that has been done by Mathieu and colleagues was to understand why our patients are refractory to rituximab, and they investigated what happened within the spleen. And what they observed is that CD19 cells were still alive in the spleen of these refractory patients, and they were consistent with plasma cells, but also with residual memory B cells. And here it clearly showed that in these patients that are refractory to rituximab, there is a large increase of this population. And when this population is phenotyped, that is represented here in red color, they observe that these cells do not express CD20, but they do express CD19. So in vitro, they assessed the potential efficacy of CD19 CAR T cells. And what they observe is that these CD19 cells were rapidly destroyed and deeply destroyed by CAR T cells. So, showing that in patients that are refractory to rituximab, targeting CD19 could be of potential interest. Another way to treat patients that are non-responder to rituximab might be to also target the cytokine BAFF, B-cell activator factor, because again, Mathieu analyzed the spleen of patients that were refractory to rituximab and observed that there were long-lived plasma cells that represent the most important part of residual B cells. And these plasma cells, as expected, produce antiplatelet antibodies. What he also showed is that after B-cell depletion, there is an important increase in BAFF within the sera of patients due to the fact that there are no more B cells to bind to BAFF. So there is again strong argument to target plasma cells in ITP patients, most particularly in those who are refractory to rituximab. But again, targeting BAFF could also be of interest. But regarding BAFF, there is also another cytokine to have in mind, which is April, a proliferation-inducing ligand. Both are produced by monocytes, and they can bind to 3 different receptors. BAFF will preferentially bind to BAFF receptor, but can also bind to TACI, while April will preferentially bind to BCMA, but can also bind to TACI. And what is important to know is that these receptors are differentially expressed by B cells. So it could be of interest either to target these cytokines or to inhibit their binding to the different receptor. What we should have also in mind is that B cells do not all express these receptors, and it depends of the differentiation stage. And if you look at this cartoon, in the early B cell differentiation, B cells mostly depend on the cytokine BAFF with BAFF receptor, whether on the contrary, plasma cells, and most particularly long-life plasma cells, depends on BCMA and April. There are also other mechanisms that participate in the survival of these long-life plasma cells that are a contact-dependent mechanism with mesenchymal stroma cells within the bone marrow. So, what we should have in mind when we are treating a patient or when we are thinking about new targets in ITP is that depending on the target, the treatment will be. Not all B cells will be affected, and this should be considered while treating, but also to understand why some of our patients are refractory to these treatments. So, if we discuss the coming treatment, so there is ianalumab, which is an anti-BAFF receptor with two actions. The first one, and most probably the most important one, is the depletion of cells expressing a BAFF receptor. So, most particularly immature, naive, and germinal center B cells, but not or less memory B cells and plasma cells that do not express BAFF receptor. And the other mechanism is that this monoclonal antibody prevents the ligation of BAFF to a BAFF receptor. So there is an ongoing phase 3 clinical trial, and I guess the data will be presented soon, at least in the ASH meeting. So, what are the potential issues using ianalumab? First, as I told you, long-life plasma cells do not express BAFF receptor, and their survival mostly rely on BCMA. So we can expect that using ianalumab will not directly impact long-life plasma cells. Moreover, it has been shown that after ianalumab treatment and B-cell depletion, there is an increase in BAFF concentration, as we observed using rituximab, but this has also been shown using ianalumab, and most particularly in patients with Sjögren disease that were treated with ianalumab. So one potential issue is that following ianalumab, we will observe an increase in BAFF concentration that could still stimulate long-life plasma cells through BCMA. And the other issue is that we are not targeting the other cytokine, April, that could also stimulate the survival of this plasma cell. That's why another approach could be the use of combination therapy using both anti-CD20, rituximab, and also using belimumab, that is a monoclonal antibody targeting a BAFF cytokine, preventing the binding of BAFF to either BAFF receptor, but also to BCMA. And in a first phase 2b trial, there was a nice response, as you can see here, as there is an ongoing phase 3 clinical trial in France. But again, the potential issue is that long-life plasma cells preferentially depend on BCMA, and this combination therapy will not impact April that could still stimulate these plasma cells. So the other approach could be to target both BAFF and April, and there is a treatment in development that is povetacicept, that is a dual inhibitor factor of BAFF and April, thus preventing the stimulation through all three receptors. So there is an ongoing phase 1 basket trial, but the potential issue will be the deep inhibition of plasma cells leading to hypogammaglobulinemia, and the concern could be infection. Other targets are CD19, CD38, and BCMA, and there have been publications, or there are ongoing clinical trial using either CAR T cells targeting B cells and plasma cells, either by the expression of CD19 or BCMA, leading to their destruction. And another way to target these B cells, or at least to increase a T cell mediated destruction of these plasma cells, is to use B or tri-specific antibodies that are currently on trial. And of course, monoclonal antibodies could also be used. And there is a trial that will start soon using tafasitamab, an anti-CD19 antibody. So to summarize these different points, when we use anti-CD20, and namely rituximab, we target early and late differentiate cells. So we could impact short-lived plasma cells, but not long-lived plasma cells, which could explain the refractoriness of some patients. Using ianalumab and targeting BAFF receptor will impact early differentiate B cells, but not plasma cells, at least not long-lived plasma cells. So we should wait for the result to know whether it's a good treatment or not in ITP. When using CD38 targeting therapy, we will have a depletion of early B cells, of germinal center B cells, but not naive and memory B cells that could participate to refueling plasma cells, which could explain why patients treated with CD38 antibodies have a relapse quite quickly after treatment, around 6 months or even sooner sometimes. Targeting BCMA will be of interest, that it will deplete late differentiate B cells and also plasma cells, but naive B cells could still be present and participate to the refueling of plasma cells, which means that using this strategy will probably need multiple treatment on time. And which might be the most interesting treatment is to target CD19. As you can see, CD19 is expressed by early, late, and also plasma cells, so it could be the most interesting, but we need data to support this. And of course, the general concern is the safety, because targeting plasma cells will, of course, decrease polyclonal IgG, leading to hypogammaglobulinemia, which could increase the risk of infection. So, moving now to T cells that are other potential targets, we could either decrease the pro-inflammatory T cell response, but also try to increase T cell tolerance, and namely regulatory T cells, as discussed previously by John. So the treatments that could affect T cells are steroids, conventional immunosuppressants such as mycophenolate mofetil or azathioprine and others. And also, as discussed by John, increasing the platelet number, whatever the treatment that is used, might be responsible for an increase in T cell tolerance. And new therapies that could be helpful in this way could be the use of JAK inhibitors. So I will not get into details because it has previously been mentioned by John, but this paper nicely showed that increasing the platelet level will increase TGF beta, leading to an increase of myeloid-derived suppressive cells that could inhibit both B cells and antibody secreting cells, and also dampen the Th1 polarization, thus allowing a remission, or at least participate to the remission of patients. We also investigated this point in the lab, and we have data that will be presented at ASH in December. And we use an in vitro culture of CD4 T cells with or without platelets. And what we observe is that adding platelets to the culture of CD4 T cells slightly increase Th17 polarizations, but also increase the expression of inhibitory molecule, mostly CTLA4 and TGF-beta by CD4 T cells. And it also increased the differentiation in regulatory T cells. And at the end, it was responsible to decrease in the proliferation of CD4 T cells. So that again supports the fact that increasing the platelet mass, whatever the treatment we use, might regulate CD4 T cell compartment and restore immune tolerance. So that could also explain the long-term response that could be observed with different treatments. Of course, TPO array, but not only. I don't know if JAK inhibitor will be the key to treat ITP, but as you know, JAK are involved in different pathway of different cytokine receptors. And there have been data, at least in vitro, showing that both baricitinib and tofacitinib, that are a broad JAK inhibitor, could dampen Th1 skewing, Th17 skewing, and CD4 T cell proliferation. They can also decrease B cell differentiation into plasmablast and decrease the secretion of type 1 interferon by plasmacytoid DC, and decrease the expression of costimulatory molecule by myeloid DC. So thus, they could be interesting as they are targeting different pathways involved in ITP. And there are ongoing clinical trials, mostly in China, using different JAK inhibitors. Another cell population that could be of interest are TFH, and we report on their increase within the spleen, but also in the blood in ITP. So current treatments that are targeting TFH are steroids and immunosuppressants, but there are other treatments that could be useful. and one that is on clinical trial that is targeting 6CR5. 6CR5 is a receptor of the chemokine 6L13 that is produced by TFH, but also follicular DC within the germinal center. And these chemokines participate to the recruitment of both B cells and TFH within the germinal center. So using a monoclonal antibody targeting 6CR5 that is expressed by TFH, but also germinal center B cells, allows depletions of B cells, but also TFH, and could be of interest. There has been a phase 1 trial in lupus and rheumatoid arthritis, and there is an ongoing phase 2 clinical study in ITP. Another mechanism is to decrease platelet descalylation, and we can use oseltamivir. So there have been publications coming from the Spanish group showing that using oseltamivir in addition to standard therapies could allow a response in patients. While used in monotherapy, no response was observed. And there was also this clinical trial comparing dexamethasone alone versus dexamethasone with oseltamivir, showing in a Chinese population that the response rate was higher. So it could be an interesting treatment with very low side effects. So to conclude, I will also say that we can use combination therapies to improve the response of treatment, using both treatment increasing platelet production in association with treatment decreasing platelet destruction, which could be low-dose steroids, immunosuppressants, SYK inhibitors, or maybe BTK inhibitors. But we are lacking data to support, to really support these treatments. But I think Thomas will discuss this later. And another way is to use multi-immune modulation. And this concept has been developed with BTK inhibition. As you know, BTK can act both BTK inhibitors can inhibit both macrophages but also B cells, but they can also have another action, notably reducing neutrophil activation and the formation of NET, preventing thus thromboinflammations, and they can also impact inflammation pathway, namely NLRP3, which could participate to thromboinflammation, but also could explain the decrease in fatigue that is observed with patients treated with risalbutinib. One can also suspect that SYK inhibition could have quite similar action, as SYK is involved again both in macrophage and B cell downstream signal. As I showed you, JAK inhibitors can also affect both T cells, B cells, and DC activations. And again, conventional immunosuppressants do also target both T and B cell activation. So to conclude, I will say that we have a growing number of potential new targets in ITP, which is a really good news that it will increases the chance of remissions. But the question remains, which one is the best for my patients when I see him during consultations. And as it has been discussed by Rick and John, there is a crucial need for a predictive factor of response in order to propose tailored therapies to our patients. Thank you for your attention.
Me now. Can you hear me? No.
Yes, yes, I can.
Oh, you can. Okay.
Yeah.
That's great. We've got time for some questions. So there are some microphones around Dr. Semple, Dr. Kapoor, and hopefully you can hear them also.
I cannot hear the question.
Hi, Sylvain. It's John. You can hear me, I think.
Yeah, I can see you.
I have two quick questions. The first one, in your data that you're going to present at ASH, when you add these CD4 positive T cells to platelets, do you know if there's a receptor ligand interaction between them, or is it just platelets are secreting things when they hit when they're added?
That's a really nice, important question. We try to use a transwell culture, but at least in our hands, it doesn't work. So I cannot fully answer your question. And we also try to inhibit TGF-beta, but also other molecules. And for now, we don't have a clear conclusion. So we are still doing experiment to better decipher what the mechanism involved is. Yeah.
The other question is completely unrelated to that one. The Tamiflu data. How does Tamiflu work? Because as I understand it, the company that makes it has specifically made it so that it only reacts with the viral neuraminidase. It doesn't react with mammalian neuraminidase. So how does it work?
In my opinion, it was that it could decrease the neuraminidase and thus decrease the descalylation of platelets. But yeah, I don't think there has been in vitro study to support that, but at least we have small reports that showed that it could help to restore the activity of other common therapies, and of course this Chinese clinical trial. But yeah, it remains to be fully elucidated, and I don't know if we can really use it for all our patients in clinical practice and whether it will be useful or not.
Okay. Rick?
Hey Sylvain, it's Rick here. Thanks for your talk. I also look forward to seeing your co-culture study at ASH in a few months. I was also wondering on that, indeed, similar to I think what John was asking, but did you also see aggregates like, for instance, with the CD8 T cells and the platelets, you see this emerging? And I also wondered, did you also have non-autologous platelets or CD4 T cells as controls in this setup? And also, if you included platelet autoantibodies into this mixture when you analyze this?
Okay, that's quite a lot of questions. Thanks, Rick. Um, I've the studies we have done, we used autologous platelets, and we did that in using ITP patients, but also controls. And what we observed is that both in controls and ITP patients, platelets modulate the CD4 T cell response. So I think it's general aspects, and it's not specific in ITP. But of course, because in ITP's platelet level is very low, this effect cannot happen and might participate to the decrease in regulatory T cells we have observed in ITP patients. And unfortunately, we did not do culture using heterologous platelets or CD8 T cells. And we didn't look at the formation of aggregates, but we used 96 well culture, and there might be really close contact between CD8 T cells and platelets. So yeah, we still don't know whether it's a contact-dependent mechanism or whether it's only mediated by soluble molecules.
One last question.
Very, very nice talk, Sylvain. First of all, I would like to know, hope your father is recovering well, okay? I would like to make a question from a clinical point of view, if possible. I think that you are reporting here that the results of a patient who underwent treatment with rituximab are probably better and can be rescued with other drugs such as the CAR T cells, CD19, focus on CD19. We have also seen numerous papers, such as the one from Takeda, with the results of CD38 that probably, given the different target, makes this drug also interesting to use in clinical practice. So I would like to know your clinical point of view of what is the potential role of CAR T cells now. Given that we don't have a session focus on CAR T cells here, but we have people from CRISPR that is there, who are developing a trial with allogenic CAR T cells in ITP and WIHA. Do you expect that probably CAR T cells could be leading an important role in the next years?
Yeah, I think there is a different way to see the problem. So we have the targets, and I hope I gave you a whole panel of the potential targets, and we also have the weapons. So weapons could be monoclonal antibodies, B or tri-specific antibodies, and could also be CAR T cells. So you can use a gun or a bazooka, and it depends on the money you have in your pocket also. So I do think that CD19 CAR T cells are effective, but they are really, they cost a lot. Their generation is quite difficult, although there are allo CAR T cells that are developed. So yeah, the problem, I think we should try the easiest, and in my opinion, the easiest for the patient is to use a monoclonal antibody. But the difficulty is that potentially this monoclonal antibody will not deplete all the targeted population because they could not reach niche such as bone marrow or the spleen, or they cannot activate the T cell response. So I have no clear answer, but in my opinion, CAR T cells should be restricted to highly difficult to treat patients. And I hope we will have good results and benefits from monoclonal or bispecific antibodies.
Okay.
Thank you.
Thank you. Okay. Sylvain, thank you so much for a very nice talk. I think we need to break now, if you don't mind. We're back again at 11:15 for the next session. Thank you.
Thanks. Bye.